Hey there, and welcome to this explainer. Today, we are mastering the safe, step-by-step procedures for administering IV Pantoprazole. It's actually a pretty fascinating drug. It literally shuts down the stomach's acid-pumping machinery right at a cellular level. But whether you're dealing with a severe reflux flare-up or managing some complex hypersecretory conditions, knowing the exact protocols for this proton pump inhibitor is absolutely non-negotiable. So we're going to break down the science, the steps, and those absolutely critical safety checks so you have complete confidence right at the bedside.
Okay, let's dive into our roadmap for today. First, we'll cover the basics of IV Pantoprazole. Then, we'll walk through the 15-minute infusion guide, followed by the 2-minute infusion guide. And finally, we'll wrap up with safety, compatibility, and storage.
So, the ultimate question we're answering today is really this: how do we safely administer IV Pantoprazole? Look, when we're on the floor, juggling multiple patient lines and super complex medication profiles, there's just zero room for guesswork between infusion protocols, right? We need a rock-solid understanding of exactly how this medication behaves, how it needs to be prepped, and how it's going to interact with the patient's existing IV setup.
All right, moving into Section 1, the basics of IV Pantoprazole, covering indications and dosages. Now, the clinical indication really dictates your dosage strategy here. Keep in mind, this medication literally covalently binds to the enzyme system of the gastric parietal cell to just shut down acid production. For short-term treatment of GERD associated with a history of erosive esophagitis, your standard adult dose is 40 milligrams, given once daily for 7 to 10 days. But look at Zollinger-Ellison, or ZE syndrome. Here, the stakes are way higher. The recommended starting adult dose actually doubles to 80 milligrams, administered every 12 hours. And for ZE patients, this dosage can even go higher. We're talking sometimes 80 milligrams every 8 hours, which is based entirely on individual acid output measurements to keep it below 10 milliequivalents per hour.
Okay, on to Section 2, the 15-minute infusion guide. Let's look at reconstitution and dilution.
For a standard 40 milligram dose, here is your step-by-step procedure. Step 1, you absolutely must reconstitute the 40 milligram freeze-dried powder vial with exactly 10 milliliters of 0.9% sodium chloride injection. Step 2, take that reconstituted solution and further dilute or admix it with 100 milliliters of one of our 3 approved diluents. Those 3 are 5% dextrose, 0.9% sodium chloride, or lactated ringers. And step 3, always inspect visually for any particulate matter and discoloration before and during administration. Now, if you're treating a Z patient who needs an 80 milligram dose, you simply do step 1 for 2 separate vials, combine their contents, and then dilute with 80 milliliters of your chosen diluent to hit that total 100 milliliter volume.
So the crucial point is right here, 7 milliliters per minute. Once you've got your 100 milliliter admixed bag ready to go, you administer it intravenously over a period of approximately 15 minutes. To actually hit that 15-minute window for the 100 milliliter volume, your infusion rate needs to be set at roughly 7 milliliters per minute.
But timing isn't just about the infusion rate, right? It's also about shelf life, and this is a critical comparison. If you only reconstitute the vial with the initial 10 milliliters of sodium chloride, that solution can be stored for up to 6 hours at room temperature prior to further dilution. However, once you create that final admixed bag with the 100 ml diluent, it absolutely must be used within 24 hours. And pay super close attention here. That 24-hour clock starts from the time of the initial reconstitution, not from the time you made the admixture. Also, a quick note, neither solution needs to be protected from light, but you must never, ever freeze them.
All right, Section 3, the 2-minute infusion guide. Let's talk about the rapid approach.
And this brilliantly illustrates the difference between our two methods. It really just comes down to a massive jump in concentration. In the 15-minute method we were just talking about, adding that extra 100 milliliters of diluent brings our final concentration down to a very mild 0.4 milligrams per milliliter. But for this 2-minute infusion, we are skipping that 100 milliliter dilution entirely. That leaves us with a final concentration of approximately 4 milligrams per milliliter. So it is literally 10 times more concentrated.
Because we skip the admixture step, this rapid process is just much more streamlined. Step 1, reconstitute your 40 milligram vial with 10 milliliters of 0.9% sodium chloride to hit that 4 milligram per milliliter concentration. Step 2, again, you've got to visually inspect for any particulate matter. Step 3, administer intravenously. And remember our Z patients, if they need an 80 milligram dose, you're going to perform this reconstitution on 2 vials and then administer the total combined volume of 20 milliliters from both vials. Oh, and for this rapid approach, your initial reconstituted solution can actually be stored for up to 24 hours at room temperature before administration.
Now, the absolute golden rule for this rapid approach is this number:
2 minutes. Whether you are pushing the 10 milliliter volume for a GERD patient or the 20 milliliter volume for a ZE patient, it must be administered intravenously over a period of at least 2 minutes. Never, ever faster.
Moving into Section 4, Safety, Compatibility, and Storage. This is all about protecting the patient.
First up, we need to define exactly what we're watching out for at the injection site, and that is thrombophlebitis. Basically, this is an inflammation of the wall of a vein with associated blood clots. Interestingly, in clinical trials, thrombophlebitis was the single new adverse reaction specifically identified with the intravenous form of pantoprazole compared to the oral studies. So this is exactly why we are so incredibly vigilant about line administration and concentration times.
To mitigate that risk, here is your non-negotiable standard operating procedure. You absolutely must administer IV Pantoprazole through a dedicated line or a Y site. You've got to flush the IV line before and after administration. And what are you flushing it with? Only our approved trio of compatible fluids: 5% dextrose, 0.9% sodium chloride, or lactated ringers. And of course, if you see any precipitation or discoloration in that line, you stop administration immediately. No questions asked.
Beyond just general line hygiene, there are some massive red flags for severe incompatibilities that you really need to memorize. First, midazolam HCl has been specifically shown to be incompatible with Y-site administration of pantoprazole. Seriously, do not mix them. Second, pantoprazole sodium for injection actually contains edetate disodium, which we all know better as EDT. Now, EDT is a chelator of metal ions. Because of this, pantoprazole might not be compatible with products containing zinc. This also means you need to exercise extreme caution if other EDT-containing products are being co-administered, and maybe even consider zinc supplementation for patients who are prone to zinc deficiency.
Now, what's really interesting about this rule is how straightforward the ultimate fail-safe is. Immediately stop use if precipitation or discoloration occurs. Look, no matter how perfectly you think you've reconstituted that vial, no matter how carefully you've checked the patient's chart for zinc or midazolam, your eyes are the final line of defense. When pantoprazole is given through a Y site, visual inspection of the line is the absolute authority. If the fluid looks wrong, it is wrong. Just stop the use.
So as we wrap up this explainer, I want to leave you with this question. Have you double-checked your lines and your patient's profile today? Mastering the 15-minute drip and the 2-minute push, well, those are just the mechanics. Real clinical excellence is understanding the chemistry happening right there in the IV tubing. So keep this safety-first mindset at the forefront of your practice. Always trust your eyes at the Y site and keep up the fantastic work out there.